Welcome to the Deep Dive. Today we're diving into something really intricate, the world of surgical approaches to the hand, wrist, and forearm.
Yeah, it's an area packed with tiny, vital structures. Really fascinating stuff.
Absolutely. And for you listening, if you want to grasp the complexities here without getting totally bogged down in medical speak, well, that's our goal today.
Exactly. We're basing this on a couple of key sources. One's a very detailed medical text on the anatomy and surgical technique, sort of the surgeon's map, you could say.
Okay.
And the other is a chapter focusing specifically on anesthesia for these upper limb surgeries, which is, just as crucial.
Right. So the mission today.
Basically, to pull out the most critical anatomical ideas, the things surgeons absolutely need to know for safe procedures in this very delicate zone, and also to touch on how anesthesia makes it all work for the patient.
Okay, let's get into it. First up, something that seems obvious but is fundamental. Anatomical knowledge. Our source really hammers this home, doesn't it?
Yeah. It really does. It's not just about knowing names. It's about having this 3D picture in your head of how everything fits and works together. It's paramount for safe dissection.
And there's this concept they highlight, inner nervous planes. What's that about?
Ah, yes. Think of them as, well, natural corridors. They're the spaces between muscle groups that happen to be supplied by different nerves.
Okay, so like a seam.
Exactly, like a seam in the fabric. By going through these seams, surgeons can get to deeper structures, bones, joints, you name it, without cutting through or damaging the nerves supplying the muscles they're moving aside.
Which avoids causing weakness or paralysis later on.
Precisely. Avoiding muscle denervation is huge. So finding and using these planes, it's a core principle for minimizing harm during extensive exposure.
Makes total sense. It's like taking the path of least resistance, but for nerves. And this whole area, hand, wrist, forearm, it's uniquely challenging because everything's so crowded, right?
Oh, absolutely. You've got muscles, tendons gliding smoothly, vital blood vessels, and all those nerves controlling movement and feeling, all packed into a really tight space. It's a delicate balance.
A small mistake could have big consequences.
Definitely. That's why the detailed knowledge is so vital.
So, to manage this complexity, the anatomy is often discussed in terms of compartments. Our source mentions this for both the hand and forearm.
Yeah, thinking in compartments is really helpful. It gives structure. In the hand, for example, you've got the thonar compartment, that fleshy bit at the base of your thumb,
Right. Thumb muscles.
mostly median nerve territory. Then the hypothenar on the pinky side, mostly ulnar nerve. You have the interosseous muscles between the hand bones.
Also ulnar nerve, mostly.
Largely, yes. And then the famous carpal tunnel, that critical channel for the median nerve and tendons heading into the hand. Thinking about these zones helps surgeons plan their approach.
And our source goes into the specific muscles, their attachments, their nerve supply within each compartment. We're just skimming the surface, but it shows the detail needed.
It really does. And similarly, in the forearm, you have compartments too. Superficial volar, that's palm facing.
Like the wrist flexors.
Yeah, things like pronator teres, flexor carpi radialis, mostly median nerve again. Then there's a deep volar compartment and a dorsal compartment on the back. Knowing which compartment you're in tells you what structures to expect. It's like a roadmap.
Okay, so moving from the map, the anatomy, to the actual journey, the surgery. The source talks about principles of surgical management. Planning seems key.
Non-negotiable. The text stresses that every single approach needs that solid understanding of anatomy surface and deeps, plus those inner nervous planes we talked about, and of course, good surgical technique.
And it's not just knowing the steps, right? There's a lot of prep work.
A huge amount. Making sure you have all the right instruments, the right sutures, imaging available if needed. If you're putting in plates or screws, they have to be ready.
Temp.
Exactly. Using x-rays or scans to plan implant sizes and positions beforehand. The whole team reviews the anatomy, the approach, the procedure itself, and even discusses alternatives. What if plan A doesn't work?
And the OR setup. Seems like small details matter.
They really do. Patient positioning is usually supine, lying on their back with the arm out on a special hand table. That table needs to be rock solid.
For precision.
Absolutely. And the surgeon needs a stable stool, good lighting, really good lighting, angled properly to avoid shadows. It all contributes.
And the tourniquet. That's standard for a bloodless field.
Almost always in hand and wrist surgery, yes.
Wow.
A pneumatic tourniquet on the upper arm. It gives you that clear view, which is just essential when you're working around nerves and tiny vessels, like working on a delicate machine.
Right. Now let's talk incisions. Making the cut in the hands specifically. Are there general rules?
There are. The source says you can technically make an incision almost anywhere, but you have to respect certain principles for good healing and function. Avoid areas that stay damp, like deep creases sometimes, and plan so the skin edges come together nicely without tension.
And they mark the incision beforehand with a sterile marker.
Always. Standard practice lets you visualize it, check placement, make sure you leave enough skin between cuts if you need multiple incisions. It's a guide.
Okay. And differences between palm side volar and back of hand dorsal incisions.
Yeah, that's important. On the palm, the subcutaneous tissue can be thin, and incisions right in the deep creases might not heal quite as well. And a big don't is making straight incisions across the flexion creases.
Why is that? Scar contracture.
Exactly. It can lead to tight scars that limit bending later on. The skin on the back of the hand is generally looser, more mobile, so sometimes you can get away with a slightly smaller incision there.
And the shape of the incision can vary too, like zigzags.
Definitely. Zigzag incisions are common on the volar side of fingers. They break up the line across the creases. On the back, you might see straight lines or gentle curves. Madaxial incisions along the side of the finger need extra care because of the neurovascular bundles running there.
Okay, let's get more specific. Approaching the finger joints, the interphalangeal joints.
Right, the hinge joints in your fingers. Surgeons often use dorsal incisions straight, S-shaped, maybe chevron. A common way in is from the side, carefully lifting and retracting the lateral bands of the extensor tendon mechanism.
Any specific precautions depending on which joint? DIP versus PIP.
Yes. At the DIP joint, near the nail, you have to be super careful of the geminal matrix where the nail grows from. It's right near the tendon insertion. At the PIP joint, the middle one, the extensor mechanism is right there under the skin.
No internervous plane there.
Correct. For more exposure at the PIP, they might carefully release and repair those lateral bands, or even create a V-shaped flap in the extensor tendon itself, which gets meticulously repaired. But the absolute key is preserving the central slip of that extensor tendon. That's vital for straightening the middle part of the finger.
Got it. What about the knuckles where fingers meet the MCP joints?
Metacarpophalangeal joints, yeah. Usually a straight dorsal incision over the knuckle, maybe transverse if doing multiple fingers. Again, no real internervous plane. Extensor mechanism is right there. Need to watch for little sensory nerve branches.
And getting into the joint itself, different options.
Several ways. You can retract the sagittal band, that little sling holding the tendon centered, or carefully split the extensor tendon lengthwise, but you have to be careful not to go too far down and damage that crucial central slip insertion at the PIP joint.
You mentioned that central slip is key.
It really is. Another option is incising along the ulnar side sagittal band, but they try to avoid releasing the radial one on the thumb side to prevent the tendon from slipping off track.
Okay, how about accessing the long bones in the hand, the metacarpals?
You feel for the bone, identify the extensor tendons running over it, then usually a straight dorsal incision right over that bone, sometimes between two metacarpals if needed.
Still no internervous plane.
Not really a true one there. So it's about carefully identifying and protecting those extensor tendons and the little cross connections between them, the juncturae. Then you make an incision in the periosteum, the bone's outer layer, and gently lift the interosseous muscles off the bone. Subperiosteal elevation.
Let's move to the wrist now. Carpal tunnel, everyone's heard of that. How's it approached?
Right, so the carpal tunnel itself, narrow passage, median nerve, 9 tendons. Roof is the thick transverse carpal ligament. Floor and sides are the carpal bones. Extends up to the wrist crease.
Landmarks.
Surgeons use the interthenar depression, that little dip near the thumb base. They can feel the pisiform bone, maybe the hook of the hamat. And there's Kaplan's cardinal line, an imaginary line helping locate structures.
And the incision has to be super careful because of the median nerve.
Extremely careful, usually centered in that interthenar depression, aiming towards the space between the third and fourth fingers. This helps avoid the palmar cutaneous branches of both the median and ulnar nerves. That's essentially the inner nervous plane there. You cut through fat, the superficial palmar fascia, then carefully divide the transverse carpal ligament itself, always watching for the median nerve right underneath, and especially its recurrent motor branch to the thumb muscles, which can sometimes have unusual anatomy.
And there's a sign when you're fully released?
Yeah, distally, you look for this little pad of fat, the sentinel fat pad. Seeing that confirms you've cut the ligament all the way.
What about the canal ligaion, the other tunnel on the pinky side?
Right, ulnar nerve and artery pass through there. Borders involve the volar carpal ligament, transverse carpal ligament, pisiform bone, hook of hamate. You palpate the pisiform, try to find the hook.
Tricky to feel sometimes.
Can be. The incision is usually zigzag or curved between those points, extending up the forearm a bit, but again, avoiding crossing the wrist crease straight on. You find the flexor carpi ulnaris tendon, move it aside gently. The ulnar nerve and artery are right there.
And then release the ligament.
Release the volar carpal ligament to decompress the nerve and artery. Important to remember, the ulnar nerve splits here into motor and sensory branches, and the motor branch often ducts under a little fibrous arch. Anatomy varies a lot here, the source notes.
Okay, moving up the forearm. The radius thumb side bone.
Yeah.
Volar approach first from the palm side.
Right. Key landmarks. Feel for the flexor carpi radialis tendon, the brachioradialis muscle belly, biceps tendon higher up, radial artery pulse. The internervous plane changes a bit. Distally, it's between flexor carpi radialis, median nerve, and brachioradialis, radial nerve.
Higher up.
Proximally, it's between pronator teres, median nerve, and brachioradialis, radial nerve. The incision is usually just above the wrist crease, thumb side of the FCR tendon going upwards. You dissect down between FCR and brachioradialis.
Watching out for it.
Radial artery, definitely. Median nerve is a bit deeper. And the superficial radial sensory nerve can be in the way lower down. Sometimes they go through the FCR sheath instead. To get to the bone itself, you often have to lift overlying muscles like pronator quadratus or flexor pollicis longus off the radius.
Now, the dorsal approach to the radius from the back.
Okay, landmarks here. Listus tubercle on the wrist end of the radius, lateral epicondyle at the elbow, and that group of muscles called the mobile wad of 3. Incision runs from Listus tubercle towards the lateral epicondyle, along the inner edge of that mobile wad.
Internervous plane here.
It shifts. Distally, it's between extensor carpi radialis brevis, ECRB, often radial or pin supplied, and extensor pollicis longus, EPL, PM supplied. Proximally, it's between ECRB, radial nerve, and extensor digitorum communis, EDC, PI supplied, the finger extensor.
Dissection.
You open the extensor retinaculum over the EPL tendon, move tendons aside. Higher up, you detach muscles like abductor pollicis longus. The really crucial structure in the upper third is the supinator muscle.
What is that?
Because the posterior interosseous nerve PI, a branch of the radial actually runs through the supinator. You absolutely have to find and protect that nerve before you release the muscle from the bone to see the radius underneath.
Very important point. Okay, finally, the ulna, pinky side bone.
Accessing the ulna is often a bit more straightforward because much of its border is right under the skin subcutaneous. You identify the head and styloid at the wrist, feel that border along the forearm, up to the olecranon, the elbow point. Incision follows that border.
Internervous plane for the ulna.
Distally, it's between flexor carpi ulnaris, FCU, ulnar nerve, and extensor carpi ulnaris, ECU, PIN supplied. Proximally, near the elbow, it's between FCU, ulnar nerve, and the inconius muscle, radial nerve. You also have to be mindful of the dorsal sensory branch of the ulnar nerve wrapping around.
And then lift the muscles.
Gently elevate the muscles off the bone superiostele. Protect the ulnar artery and nerve, especially near the wrist. Proximally, you note the triceps insertion in the path of the ulnar nerve going behind the medial epicondyle, the funny bone spot.
Wow, that covers a huge amount of surgical anatomy. So detailed. Now, let's shift gears to our other source anesthesia, equally vital.
Right, absolutely critical. And the landscape has changed, More outpatient surgery, so managing pain after the patient goes home is a huge focus.
And regional anesthesia nerve blocks plays a big role.
A massive role. Blocking the specific nerve supplying the surgical area often gives much better pain relief than general anesthesia alone. Plus, less nausea, less vomiting. Patients generally feel better and recover faster.
And the blocks can last longer now, even continuous relief.
Exactly. Long-acting local anesthetics help, but for really sustained relief, they can place a tiny catheter near the nerve.
An indwelling catheter.
Right. And a small pump infuses local anesthetic continuously, sometimes for days, even at home. This bridges that gap when a single shot block would wear off, which can be a really rough period pain-wise.
So how do they decide? General anesthesia, regional, or both? What goes into that choice?
Several things. How long is the surgery? Very long ones might favor general for patient comfort. Does the surgeon need to check nerve function right away? A block would interfere with that initially.
Equation factors too?
Of course. Patient's overall health, anxiety levels, any specific medical conditions like lung problems if you're considering certain neck blocks, and patient preference, naturally.
But regional seems to have a lot going for it based on our source.
It really does. Potential benefits include smoother or R flow blocks can often be placed beforehand. Easier management for patients with certain conditions. That combo of anesthesia and post-op pain control from one technique. Less nausea, quicker recovery, maybe even less post-op confusion or cognitive issues, especially in older patients.
And different blocks for different areas.
Yep. Shoulder surgery often uses interscaling blocks near the neck. Elbow might be interscaling, supraclavicular or infraclavicular below the collarbone. Down in the forearm and hand, you might use infraclavicular, axillary in the armpit, or even IV regional for shorter things.
IV regional.
Yeah, beer block. Inject anesthetic into an arm vein while a tourniquet keeps it in the limb. Good for shorter procedures.
But regional isn't always an option, is it? Contraindications.
Right. Definite no-goes include acute nerve injury in that limb, progressive neuropathy, infection right where you'd stick the needle, patient refusal, or serious bleeding problems. Then there are relative ones, maybe stable nerve issues, severe lung disease for high blocks, active infections elsewhere.
And managing pain isn't just about the block, is it? This idea of preemptive and multimodal analgesia.
Good point. Preemptive means starting pain meds before the pain really kicks in, even before surgery sometimes. Multimodal means using different types of pain relief together.
Like combining things.
Exactly. Maybe an NSAID plus acetaminophen, maybe something like gabapentin for nerve pain alongside the regional block. The idea is to attack pain from multiple angles, often meaning you need lower doses of each drug, reducing side effects, especially from opioids if they're needed at all.
And like with surgery, consent for anesthesia is vital.
Absolutely. The anesthesiologist has to explain the options general, regional, the specific block, along with the risks and benefits of each. It's a shared decision informed by the patient's choice and the medical team's recommendation for the safest outcome.
Finally, let's touch on complications. Both general and regional have potential risks, right? It's not risk-free either way.
No medical procedure is entirely risk-free. General anesthesia can have post-op nausea, urinary retention, rarely things like corneal abrasion or nerve injuries from positioning. Interestingly, the source notes ulnar nerve injury at the elbow is statistically more common with general anesthesia than regional.
That is interesting. And regional risks.
Potential risks include nerve injury from the needle or catheter, infection, bleeding, or hematoma at the site, and rarely local anesthetic toxicity if the drug gets into the bloodstream accidentally. But, with ultrasound guidance now widely used and careful technique, these risks are generally quite low.
So overall, regional seems to be increasingly favored for upper limb surgery.
For many patients, yes. The potential for superior pain control and a smoother overall experience makes it a very attractive option.
This has been incredibly insightful. It really drives home the sheer complexity and elegance of the hand, wrist, and forearm, and the level of precision needed by surgeons, supported by sophisticated anesthesia.
It really is a team effort, isn't it? Surgical skill and anesthetic management working hand in hand for the patient.
Definitely. And thinking about this intricate network we've discussed, it makes you wonder, doesn't it? What other seemingly small, compact areas of the human body hold similar levels of anatomical challenge and fascination for doctors? Maybe something for you, our listener, to ponder. Thanks for joining us on The Deep Dive.